All right. Hello, everyone. Gonna give everyone else a little bit more time to show up and join. Just let me know if you can hear me well. So today we'll be going over some neuro cases. So there'll be just a couple more scenarios, and I'll be giving you the explanations behind the answers, and we'll be in a similar fashion of what we did before. Okay. So let's begin with the first one. Okay. So our first scenario is on back pain. And our patient is Mr. McGee. He's 57 years old. He's a lorry driver, and he was diagnosed recently with a bronchial cancer. That was 8 months ago. He presents to his GP with back pain, which has lasted 2 months and has been getting progressively worse. The pain is in the middle of the back and is worse with moving or coughing. Now, we have a couple of key sort of factors here that we need to consider. So he's above 50. He's had a recent cancer diagnosis. He has back pain, and it's been getting progressively worse. And now we have the location of the pain. So all of these are red flag signs of back pain. So it's in the middle of the back, which indicates potentially a thoracic problem. He's had prior cancer, which might indicate compression of the local nerve roots through metastasis. And it's been happening over the past 2 months and getting worse. So it's quite relatively sudden onset. And it's been more than what you would consider with mechanical back pain. So the GP rightly suspects cancer that has spread to thoracic vertebrae and is compressing the local nerve roots. So this is a sort of stereotypical presentation of cord compression. That's different than Corticospinal syndrome, where the problem is at the tail end of the lumbar spine. This can happen anywhere, commonly in the thoracic. So the first question that you would get for this is diagram, and they'll ask you to label it. Now, this is a sort of 3D structure. So 3D structures of things that you commonly know is quite tricky. So you should be able to sort of identify the key features. So first of all, which part of the spine do we think this is? Well, the giveaway here is the structure H. It's a lateral gray horn. And the lateral gray horn is only found, or most commonly found, in the thoracic spine. This means this is a picture of the thoracic spine. So the first thing that they're going to ask us is the dura mater. So that's the first layer here. That's the first layer, meningeal layer of the spinal cord. That's the dura mater. Then the second one is the pia mater. Pia mater means a thin layer. So it's much thinner than this dura mater, which has 2 layers. That's A and B. C, well, we have to think of this. So it's not labeled what is posterior and what is anterior. However, we can see that there is a root ganglion. And the root ganglion is always on the dorsal side. This is the dorsal side, and this is the ventral side. So that'll be back, and that'll be front. So the C is therefore the ventral root of the nerve of that spinal section. Then D will be the dorsal root of the nerve. We already established that E is the root ganglion because it's on the back. And F here, if this is the back, must be the dorsal part. So this is a dorsal gray horn. G is a dorsal funiculus. So that's the white matter part. And H is the lateral gray horn. This is just all of them together, all in one picture. So what we're looking at here is a thoracic spinal cord segment. So how do we know this? Well, let's look at a thoracic cord segment here. So it's comprised of, so this is the posterior, this is the anterior. So it's comprised of the white matter, which is highlighted in red, and the gray matter, which is highlighted in green. So the back side is called dorsal, rather than posterior. This is the lateral funiculus, and this is the ventral funiculus. When we talk about the white matter, we describe them in terms of funiculi. And a funiculus basically is just a bundle of axons. Just a fancy way of saying that. Then we have the gray matter, which is the dorsal horn, so that's the one in the back. The intermediate horn, which is most commonly seen in thoracic spinal cord segments, and then the ventral horn. So the funiculus is in white matter, which is a bundle of axons, whereas the horn is gray matter, which is the cells and the neurons, the bodies. So one of them is the bundles, and the other is the cells and neurons. And the reason why it's dorsal and ventral is to do with the embryology. So the naming of things always comes back to the embryology. So this is why embryology is so important. So the dorsal aspects originate from something called the alar plate, which is it's part of the roof plate. And it's responsible for the sensory inputs from the periphery. The dorsal aspect from the alar plate. So as this develops, this becomes the sensory part. So the dorsal part is the sensory part. Whereas the ventral aspect is originating from something called the basal plate. And that handles all the motor outputs. So this is what it looks like when it's still forming with the central tube. And this is what it becomes once it fully matures. And as you can see, the functions are preserved. So all the nerves which are sensory are on the top with the alar plate, which eventually become the dorsal horns, and all the ones on the basal plate become motor outputs, which become ventral horns. And another thing with spinal cord segments is the organization of the structure. So this is a 2D image. This is what you might be more commonly used to, rather than the 3D section. And the anterior/ventral root is the axons of the motor neurons. So this root is the axons. Whereas the posterior root is the sensory motor neuron. Now, the dorsal root ganglion is where the afferent, the ones coming from the muscles and coming from the body towards the spine, that's where they have their nerve cell bodies. Whereas the ones which are efferent, the ones coming out, have ganglions closer to their target organ, to the target site. And the anterior root contains axomotor neurons, contains the cell bodies within the gray matter, and there's also something called the anterolateral sulcus, which is not pictured here, but that's where it originates from. And it contains all the efferent fibers. The dorsal ones are posterolateral, they contain the afferent fibers, that's the sensory information, and then the dorsal root is, there's no synapsing at the ganglion, so that's unipolar. This is a ganglion where there's no synapse, it's just the body, and the synapsing happens within the horns. And it's a dorsal root only, so it's only afferent fibers. Now what you can see here is that these fibers, they merge together to create the spinal nerve. So every spinal nerve has an input, so the afferent, and an output, the efferent. And they travel together as one. However, they get separated as they enter the spinal column and then enter the spinal cord. But then when they travel together, it's a different problem. So if you have a lesion here at this edge, you might have a sensory only issue. Likewise here, if there's a lesion at this edge, it's going to be a motor only. However, if you have a lesion here, like such as neuropraxia, like a stretching of the nerve, especially in the C-spine, common with hand injuries or upper limb injuries, then you will have both the sensory and the motor affected. And likewise, if you have something pressing on the posterior side, it will mainly cause you sensory symptoms. Whereas if it's something pressing from the anterior side, it's less common because the bones usually go from the back, then it's going to be a motor problem. And of course, if you have an invasive cancer, which invades thoroughly through here, then you'll have both sensory and motor neuron symptoms. Okay, let's get back to our scenario of back pain. So the story continues. The GP wants to assess which local nerve roots are damaged. And we do this through something called a dermatome. We try to assess the dermatome. Well, first question, what is a dermatome? And what bedside test will help identify the loss of sensation in that specific dermatome? Well, with dermatomes, the definition that we have is that it's an area of skin supplied by a nerve fiber from a single root. That's a dermatome. So if we were to say the C4 dermatome, like in our previous video, which is the shoulder, that refers to the area supplied by a single nerve root, C4. It's an area of skin supplied by nerve fibers from a single root. And then what bedside test will you do to help identify the loss of sensation? Well, there's two that you can do. So you do pinprick, so that's something sharp, which tests the spinothalamic tract, which is the pain tract. And then you do something called fine touch, which stimulates the dorsal column medial lemniscus pathway. So what does this mean? So if we look at the different axon tracts, we have different myelinated axon tracts. We have the fasciculi, right, with the dorsal column, which is the gracilis, and the cuneatus, so gracilis cuneatus. And the gracilis is responsible for things like fine touch. So the dorsal column is gracilis, which is fine touch, vibration, and it's from the ipsilateral limb, so it's the same side. And the gracilis is usually in the lower limb. The cuneatus is the exact same, but it's more in the upper limb. And this is the differentiation here is to do with the different segments having different shapes and different sizes. So gracilis is the legs, cuneatus is the upper body. Then we have the spinocerebellar tract. And this is proprioception from the limbs to the cerebellum. This is how the cerebellum knows that you're balanced, and it takes inputs from the tendons, from the muscle spindles within the muscles to sort of ensure that it knows the joint position. Then we have the spinothalamic tract. Now the spinothalamic tract, which is the pain tract, is in the anterior part of the horn. And this is very important because it sends pain and temperature, and it's from the opposite side. Now why is that? Well, the lateral spinothalamic tract is on the same side. However, the anterior one is on the other side. So the spinothalamic tract takes the temperature from the contralateral side, and this is because it decussates. So when you have a nerve coming in, it comes up, it goes here, synapses, and then goes up. So it's a decussation. So if you get this part damaged, so let's say the left side is damaged, you'll have symptoms on the right-hand side. And this is because of this decussation that occurs when the nerves travel. Okay, so that's the spinothalamic tract. So that's all the sensory ones covered. Then we have something called the corticospinal tract, and there's two of them. There's the anterior one and the lateral one. Now, this has to do with the decussations. So the anterior corticospinal has motor to the on the same side, so ipsilateral and contralateral. And this is mostly axial musculature. So this means the trunk muscles, the back muscles, the muscles that are close to the spinal cord are supplied by the anterior corticospinal. Now, the lateral corticospinal is to do with limb musculature. And this one is on the same side. We also have the corticobulbar, which is to do with the brainstem via the cranial nerves. That's not pictured here, which we'll get into a little bit later. And we have also something called the anterior wide commissure. And this one detects pain fibers and temperature fibers and anterior cortical tract fibers, and that's due to the decussation. So this part here is very important, because if you have a lesion that starts from the center, then you'll have both motor and sensory problems. And the sensory will be on the side where the temperature crosses over. This is because of the decussation. They cross over. here. And if there's a problem there, then you'll have issues with the pain, temperature, and motor functions. Okay. Let's move on to the dorsal column medial lemniscus pathway. So the dorsal column medial lemniscus pathway is quite important, as we've seen before. It travels from as a nerve from the spinal ganglion, and it goes up through either the gracilis or the cutaneous, and it goes all the way up, and then it decussates. And what happens here is that the primary synapses with the secondary at the glacial nucleus, and this is at the medulla. So this here is the medulla that we're looking at. And this is the dorsal column nucleus. This is why it's called the dorsal column. So it goes through the posterior column, or the dorsal column, all the way up. That's a column. And then we have the internal arcuate fibers, which carry the secondary afferents, and they cross over. And this passes through the medial lemniscus. So that's why it's called the dorsal column medial lemniscus pathway, because it travels up through the dorsal column in the spine, and then when it reaches the medulla oblongata, it goes through the medial lemniscus pathway all the way to the ventral posterior nucleus of the thalamus. And then you have a tertiary afferent which passes through the internal capsule and into the sensory cortex. So so just to summarize this, what do we feel? So if we feel a sensation such as vibration or light touch, it gets passed through the sensory part, so the afferent. It goes up through the glacial nucleus all the way to the glacial nucleus of the medulla through the dorsal column pathway, decussates at the medulla, and then travels to the brain through the medial lemniscus pathway. And then it hits the VPL of the thalamus, and then from there it goes to the somatosensory cortex. Now, if it's T6 and less, it's the facilis gracilis, and if it's T6 and above, it's the fasciculus cuneatus. That's the differentiation. So lower limb and upper limb. So that's the dorsal column pathway. Then what we have, this is not the dorsal column, this is the spinothalamic tract. And what happens here is something similar. It's a different axon type. It's an A delta C fiber. So these are less myelinated. And they respond to pain, itch, and temperature. And the decussation occurs at the spinal cord. So as soon as the spinal ganglion comes, it goes through the anterior commissure and it decussates to the anterolateral spinothalamic tract. And then it travels all the way up, all the way to the VPL, which is in the thalamus. And then from there, it goes to the somatosensory. So here, it's a much longer trajectory. So it decussates and then travels all the way up. And this is the spinothalamic tract because it goes to the spinothalamic column. Once again, it's a little bit different, but you have a noxious stimulus. So this could be action potential through the primary afferent. You feel pain, you feel inflammation. It goes to the dorsal horn, and the cell bodies are within the spinal ganglion. It goes to something called the substantia gelatinosa, which you don't really need to know, but it's just for extra details. And then it goes all the way to the anterolateral funiculus, which is in the bottom, and travels up, and travels through the spinothalamic pathway, past the medulla, past the midbrain, into the thalamus. At the thalamus, it's the ventral posterior nucleus, so the VPL again, and then it's modulated through sort of gate pathways. So this is the gate theory. So if you have upper stimulation, the pain will be less. And then it goes through the internal capsule into the brain. So slightly different pathway. Let's get back to our back pain. So there's the concern that the tumor could compress the spinal cord, causing damage to the corticospinal tract. Now, what type of motor neuron lesion is this that it's causing damage to the corticospinal tract? Well, it's an upper motor neuron lesion. And this is because it's compressing the upper nerves right within the spinal column. A lower motor neuron lesion would be one where the lower nerve, the one that's closer to the one that's supplying the affected site, that would be a lower motor neuron lesion. And where do most of the fibers in the corticospinal tract decussate? Well, we know this. This is the pyramids of the medulla. And where in the spinal cord is the corticospinal tract located? Well, once again, mostly it's lateral in the lateral funiculus, 15% is in the ventral funiculus. So let's just visualize this again. So this was the sample question. This would all be 1 mark questions. And it's basically trying to see if you can apply the knowledge of the different regions within the spinal cord. And it's quite a tricky way to do this without the visual representation. However, this is the type of questions you'll be getting in an exam, and it's usually just 1 mark questions. But a lot of these 1 mark questions can add up quite quickly. So let's have a look at the corticospinal tract. The corticospinal tract, this is the primary motor cortex. What we have here is that it's trying to connect the lower motor neurons in the spinal cord with the brain. How does it do this? So this is from top to bottom because this is the motor neuron. So the axons pass through something called, so they start in the primary motor cortex. They pass through something called the basi's pedunculi. They decussate at the pyramid, so that's the medulla, so it's always at the medulla. 85% are on the lateral side, 15% crossover. And it goes down and down and down. So 85% crossover, 15% are on the same side. And then it terminates towards the lower motor neuron lesion. Now this here, if we have a damage at any point here, so if there's a damage here, that's an upper motor neuron lesion. If we damage these nerves, that's a lower motor neuron lesion. So this is upper, that's lower motor neuron lesion. And the reason for that is that because it's the upper motor neuron that controls everything, and the lower motor neuron is the one that enacts the effect. So if you have a response from the brain, okay, I want you to move a muscle, it will send the signal, and then it will enact it through the lower motor neuron. And in this case here, we have the important structures of the basis pedunculi and at the pons where the fibers get broken down into these bundles. And this is a sort of simplistic way to visualize this. So we have the motor cortex, we have the brainstem or spinal cord, and then we have the muscle. If we do damage to the lower motor neuron, we get a lower motor neuron lesion. If we do damage to the motor cortex, we get an upper motor neuron lesion. And this is applying to both the corticospinal and corticobulbar. Another term for this, by the way, is a pyramidal because it goes through the pyramids of the medulla. So it's a pyramidal pathway. All right. So back to back pain. So there's going to be a series of following questions, and they all assume that the damage is in the thoracic region. So the questions will always tell you what they want from you. So if it says, okay, here's a list of questions, and they will give you a set of circumstances so that it narrows down the question. Because otherwise it can be quite vague. And so this is all assuming that the damage is in the thoracic region. So if the pyramidal tracts, so that's another term for the corticospinal tracts, the ones we just described, of the left and right are damaged, what is the expected loss of function? Well, if the pyramidal tracts in the thoracic region are damaged, then we know that it's going to affect the lower limbs. If it was in the cervical cord, like the C-spine, it would also affect the upper limb. So what we know is that function-wise, we will lose function in the lower legs. However, if we go back, we will see that this part also triggers the axial muscles. So this part, the anterior spine aspect, provides fibers for the axial muscles. So we will have two damages. We'll have paraplegia bilaterally, so they won't be able to use their legs. That's paraplegia, which means bilateral loss. We will have loss of the axial trunk and muscles. So we will have the loss of these functions. And this can mean postural problems on top of inability to use the legs. So this might mean that the patients might have difficulty sitting. So it's not that they can't even move, they might not even sit well. And they will require wheelchairs. Now, what will we expect the Babinski response to be? So the Babinski response is a plantar reflex, S1, S2. And what it does is that when you have a noxious stimulus, there'll be a picture here, and it's applied to the foot, the toes will curl down. However, if it's a thoracic damage and it's an upper motor neuron lesion, you'll have something called an upgoing plantar, which is a fanning of the toes. Clinically, this is very difficult to distinguish. If you just try running your finger or even anything down the base of your foot, the plantar aspect of your foot, you'll see it's quite tricky to see if the feet are going one way or the other, and if the toes are pointing one way or the other. Now, the knee-jerk reflex, what will we expect there? Well, we'll expect a brisk reflex. And why is that? Well, if we have our upper motor neuron here, then our lower motor neuron, and that's our muscle. If you cut off the upper motor neuron, think of that as the control center. So the control center is off, which means that there's no way to restrict the reflex. And this upper motor neuron control for the reflex is there to protect the tendons, to protect the muscles. So the reflexes in an upper motor neuron lesion will be very high because there's nothing holding them back. Compared to a lower motor neuron lesion, well, there will be no reflexes because you try to provide the stimulus and the effector nerves do not work. So you're not going to have any reflexes. The following picture here is going to be of the normal plantar response where the toes go down, and the Babinski sign, which is the extensor plantar response, which is the fanning of the toes and the toes going up. Now, when we are born as little children, little babies, newborn babies have an extensor plantar response. This is one of the things you check for when you do a newborn examination. And the reason for this is that babies develop from head to toe, so from cranially to caudally. And their reflexes yet are not developed properly because of a lack of development of the caudal aspect of the spinal cord. So they will have this quasi upper motor neuron lesion just because their higher upper motor neurons are not developed yet. That's the Babinski sign. It's quite difficult to elicit clinically. Okay, let's talk a little bit about segmental variation. So if we look at the cervical spine, this is the usually larger. So cervical lumbar are usually larger because they innervate the limbs. They have higher sensory inputs, which we can see with the long horns. And they usually affect the smaller muscles, especially in the cervical aspect. And this is the fine dexterous ability, so like wiggling your toes, wiggling your fingers. And it's very sort of distinct abilities. Whereas, for example, the thoracic is much smaller in size. And that's because there's fewer sensory inputs to deal with. And it innervates much larger muscles. So it's the muscles of the trunk, it's the muscles of the back, the legs. These muscles are powerful, yes. However, they do not require as much fine control, and there's fewer axons and neurons and connections to be made. So if you imagine the human homunculus and how many things you have to do with your hands, your fingers, your face, and like from your neck as well, there's so many different things that you need to feel. Whereas in the back, there's not that many with the thoracic unit that you need to feel. Likewise, with the lumbar spine, it's much thicker, and this is because it innervates a much larger aspect of the body. So it innervates the legs, which are on the lower limbs, which are massive muscles, massive structures. We have also the sort of the surrounding area of the buttocks, which is the largest muscle group in the body. So therefore, the ventral horns are much larger here. And then we have the sacrum. And the sacrum is quite small because it's towards the tail end. However, the relative size of the sacrum, of the gray matter, is quite large. And that's to do with the perineal sensations. This is the genitalia, this is the anus. And for these, we have a special sort of relationship here where it's much thicker. There's much more of the gray matter. So to summarize, cervical lumbar, have larger dorsal and ventral horns. That's because it's limb innervation and high sensory input, and they're responsible for smaller muscles. Thoracic and sacral have relatively smaller dorsal and ventral horns, with the exception of the sacral, which is thicker. And this is because it's the axial muscles with fewer sensory inputs and fewer smaller muscles. Now, the lateral horns, which are prominent in the thoracic and lumbar segments, are present because they have cell bodies of the sympathetic nervous system. And this is how you differentiate them with the thoracic and some parts of the lumbar, because you will not see that in the cervical or the sacral. Lateral horns are the sympathetic nervous system. So going back to our scenario here, the patient starts to tell us that they cannot feel the pinprick sensation on their feet. What does this mean? So this means that there has been some damage to the spinothalamic tract, because the pinprick is to do with pain. That's driven by the spinothalamic. Now the GP wants us to assess proprioception. How would you go about assessing this? And this is 4 marks, so they want quite a lot here. And what you need to say is the test and how you perform it. That's what you get the 2 marks. And there's 2 tests that you do. So one is for the lower limbs. This is the heel to shin test, which involves raising the heel on one leg and going up and down the shin of another. That's the heel to shin test. That's your 2 marks. Then the finger to nose, so this is the pass pointing from your neurological examination. And what you do is from finger to the patient, to the nose of the examiner and back and forth, and you do that with both sides. And then you see what you check for. You check for pass pointing. And pass pointing or hesitancy is the inability to touch the finger, or being unable to, or doing it very slowly. And then finally, which sensory pathway is damaged in proprioception? Now, this should be an easy answer. This is just 1 mark. But from all that we've learned, it's going to be the dorsal column medial lemniscus pathway, or the dorsal column pathway. And that's just the one, because that's responsible for proprioception, fine touch, and vibration. Okay. So next question is more theoretical. So why might a patient with a spinal cord compression have urinary retention? This is a good question, because there's 2 parts to this. So in order to urinate and void, we have 2 aspects. We have the contraction of the bladder, so that's the detrusor, and then we have the voluntary contraction of the sphincter. So sometimes the bladder might contract, but we can control it because it's not a convenient time to pee. So those are the 2 aspects. Now with a spinal cord injury or compression, it fails at 2 points. So it's the lack of, so there's no detrusor contraction because there's damage to the pelvic splanchnic nerve. And the pelvic splanchnic nerve is from S2 to S4. And that's known as the micturition center, so the peeing center. When you get a compression in the form of an upper motor neuron lesion, the acetylcholine cannot act on the M3 receptor via the parasympathetic pathway. Therefore, there's no detrusor contraction, and therefore you get retention. So the bladder itself doesn't want to pee. At the same time, in S2 and S4, you have something called Onuf's nucleus, which is responsible for voluntary control through the pudendal nerve. And if you get an upper motor neuron lesion, you can't voluntarily relax the sphincter, so you get something called a tonic constriction of the sphincter. So the natural state of the sphincter is to be constricted. And then when you apply your sort of voluntary control through the pudendal nerve, it relaxes. So when you try to force your urination, that's what that is. And now because you have tonic constriction because of lack of voluntary control, you get no micturition. Therefore, you get retention. So it works in 2 ways. And which spinal nerves, we sort of touched on this. So which spinal nerves give rise to the parasympathetic fibers? Well, there's an easy way to remember this. S2, S3, S4 keeps the pee off the floor. It's not only pee, it's also bowel control. So S2, S4 keeps the pee and poo off the floor. That's a good way to sort of remember the nerves responsible. Okay, so that's the autonomic pathway. And when we look at the autonomic pathway, it's quite dominant here. So we have the parasympathetic and the sympathetic. What we have a look at here is that from the sympathetic, it's mainly from T1 to L2. This is why we get the lateral horn. We also have some parasympathetic fibers from the pons, midbrain, and medulla, which is the cranial nerves. And we also get the parasympathetic from S2 to S4, which controls the bladder. The parasympathetic, if you think about rest and digest, peeing and all that stuff, that's the parasympathetic, and sympathetic is the opposite. And this is how it relates to the spinal cord. We're going to go through some bonus questions. So this is just mostly a recap. The first question might be label the following parts. It's another labeling exercise. And this is just a similar picture I used before. So the first one here, A, is the fasciculus gracilis, because it's more closer to the midline. B is the fasciculus cuneatus, which is in the upper limb. C is the spinocerebellar tract, which is cerebellum. D is the lateral corticospinal tract, because it's quite close, it's lateral. E is the spinothalamic, because it's at the anterior. F is the anterior corticospinal, and H is the anterior right commissure. That's where all the decussation happens. Another bonus question. So compare and contrast the corticospinal and corticobulbar tracts. So the corticospinal these are the descending pathways from the brain to the parts below. The corticobulbar is to do with from the brain to the cranial nerve nuclei. That's the only difference. Their decussation is similar. So they're both descending motor neuron pathways. They both pass through the basal pedunculi, and they both decussate in the medulla. The difference is that the corticospinal goes from cortex to spinal cord motor nuclei, and corticobulbar goes from the brainstem to the cranial nerve nuclei. Bulbar, think brain, it's to do with the head, so it's controlling the muscles of the head and the functions of the head and neck. What are the differences between upper and motor neuron lesions? Well, this answer here is that the upper motor neuron lesion can be caused by cerebral infarctions in the brain or something in the corticospinal tract, so in the spinal cord, whereas lower motor neuron lesions is usually either a peripheral nerve or it's at the nerve root. And this is what we were talking about when we drew the horn. So that's like the horn there. We get our fibers coming out, and then they join to become, so that's our ganglion. And when we get a lesion at this point, at the nerve root, then that is also a lower motor neuron lesion. So upper motor neuron is brain and spine. Lower motor neuron is peripheral nerve or at the nerve root. What are the features of upper motor neuron lesions? So this is muscle weakness. This is increased tone and increased reflexes. The reason for increased reflexes, we've discussed this, is because it's a lower motor neuron overactivity. This is a sort of release phenomenon. So if you think about the upper motor neurons controlling the situation, they are the upper management. They're controlling the reflexes there. And if you don't have the upper management, then they're released from the control, and it's the more primitive reflexes, the ones that don't require the brain or the spinal cord, they become more prominent. On the other hand, if it's a lower motor neuron lesion, with a lower motor neuron lesion, it's the opposite. So we have muscle weakness, we have wasting, we have reduced tone because we don't have any passive tone, and we have fasciculations. Fasciculations are these spontaneous muscle twitches, and they're caused by increased receptor concentration of muscles because of lack of innervation. So In an attempt to try to stimulate the nerves, there will be increased stimulation because there's no innervation, and you will get these flickers. And with these flickers, you will get these fasciculations. Once again, the reflexes are reduced because there is a motor neuron lesion. It's either because the muscles become flaccid, and then there's eventually atrophy. The upper motor neuron tries to send signals, but there's no response. So the upper motor neuron thinks it's doing its job, and the lower motor neuron just doesn't respond. Now, if we put it into a table like so, if we ask about different signs, so upper motor neuron is always a CNS damage to the brain, whereas the other is like a plexus or peripheral nerve system. And the tone is flaccid, whereas the upper motor neuron is spastic. The way you differentiate this is by examining, and you do this through like a cochlear rigidity, or you try to make sure that they can, you try to passively stretch their hand or passively stretch their legs. You'll have a lot of resistance trying to do that. There will be weakness, but that's because of loss of muscle bulk rather than due to the nerves not working, which is in the upper motor neuron. Reflexes will be absent, whereas they'll be exaggerated in the upper motor neuron. Babinski will be negative, so that means normal toe flexion, but positive in upper motor neuron because of the spasticity and because of the lack of higher cortical function. And finally, the different injuries at different levels. So there's a nice way to summarize this. If it's between C1 and C5, you will have problems with the upper limbs and the lower limbs, so quadriplegia. You'll have muscle weakness, increased tone, and increased reflexes, which is upper motor neuron. And you might have some lower motor neuron signs if there's damage to the spinal nerves. Of course, a key mention for C1 to C4 is that some of these muscles are responsible for breathing. So C3, 4, 5 keeps the diaphragm alive. And if you can't breathe, well, then that will kill you unless you're intubated, ventilated. If it's a C5 problem, you will have control of your shoulders and biceps because that's so you lose the control of your shoulders and biceps, but you'll have no hand because that's C6 and below. So hand involvement will be fine, and you will have no lower limb movement. That's because C6 and below is your hand and wrist, and the shoulders is C5 and C4. Now at C6, that's your wrist control, but no hand control. So hands, your fingers, that won't work. That's C7 and C8 only. And of course, you will have no limb control. And C7, T1, so this is most of your upper limb control will be intact. Your fine dexterous ability might be slightly affected because the T1 is responsible for the ulnar and medial nerve, but lower limbs will not be working at all. Now for lesions from T3 to T12, upper limbs completely normal, so you'll be paraplegic, which is the lower limbs. You'll have poor trunk and abdominal muscle control from T1 to T8, and this is just because these are the muscles that are innervated by T1 to T8. So you'll have lack of core stability causing postural problems, so there'll be difficulty sitting, there'll be difficulty maintaining your posture, so you will need a wheelchair. Once again, there'll be upper motor neurons. Between T12 and S2, you will have lower motor neuron signs in the lower limbs because of spinal cord terminating at L1. So from L1 downwards, which we can see here, from L1 downwards, it's a lower motor neuron problem. So if you have a spine lesion at L2, well, that will cut through the low motor neurons, not the spinal cord. And there'll be decreased control of hip and flexors. This is just a summary chart. C1 to 5 will be upper motor neuron lesions and lower limbs. If there's damage to spinal nerves, you might also have some lower motor neuron signs. T3 to T12, so upper limbs normal because that's from C1 to T2. Lower limbs will have upper motor neuron signs. T12 to S2, so upper limbs will be normal. Lower motor neuron signs will be in the lower limbs. And if it's the sacral region that's also affected, you might have difficulty with, you'll have incontinence. So you won't be able to control your bowel and urination. Because that's our scenario 4, that's our back pain. Now we're going to go to a different scenario. And this scenario is a road traffic accident. So in this scenario, we have a young man called Mr. Ingles. He was involved in a road traffic accident. He was knocked unconscious and his friends called an ambulance. He briefly recovered in the hospital, but later became unresponsive. When you examine him, you notice a large bruise on the left temporal region with a dilated left pupil. So let's analyze what we've been told here. So we're told that he was involved in a road traffic accident. That always alerts us. He might be needing a CT scan. He was unconscious, and then he recovered. And then he became unresponsive again. So this is called a lucid period. So a patient might lose consciousness, they might deteriorate a little bit, then they recover, then they become unresponsive again. And this is sort of characteristic or even pathognomic to a certain extent of an extradural hemorrhage. This is the hemorrhage to the external blood vessels of the brain. We have this lucid period. Another example would be, for example, any contact sports, like a rugby match, someone gets tackled, they lose consciousness, they regain consciousness only to become responsive and then deteriorates very rapidly. And we'll go into why that happens. So back to the anatomy, which muscle is responsible for pupil dilatation and its innervation? So that's the pupillary dilator muscle, and it's a sympathetic neuron innervation. Now, which muscle may not be working if the pupil is dilated? Well, it's the pupillary constrictor muscle. And the reason this is important is because your diameter of the pupil is controlled by the balance between the sympathetic and the parasympathetic system. The sympathetic wants to dilate the pupil, whereas the parasympathetic wants to constrict it. So that's my mydriasis and meiosis. Meiosis, so that's constriction, and dilatation is mydriasis. And it's the balance between these two that enables us to change our vision. Now, the question wants us to describe the innervation of the pupillary constrictor muscle and also try to explain why the pupil is dilated. Well, we know that the muscle that's responsible is the pupillary constrictor muscle. And we also know that it's innervated by the parasympathetic region as a system. It's also innervated by the cranial nerve 3 through the ciliary ganglion. So if there's ganglion involved, that's usually parasympathetic. Now, in trauma, this cranial nerve is damaged. And the reason it's damaged is because the pressures within the brain cause what is called an uncal herniation. The brain herniates down and presses on the nucleus within the cranial nerve 3. Now, this region is called the Erdinge-Westphal region. And it is a parasympathetic nucleus of cranial nerve 3. And its synapses at the ciliary ganglion. And the ciliary ganglion, I'll have a picture up of this later, is where we have where it interacts with the pupillary constrictor muscle. So the picture here. So the Erdinge-Westphal goes this way. Now, what happens here is that this decreased parasympathetic signals due to this herniation results in sympathetic taking over. So it's a fine balance. So the sympathetic nervous system takes over. What does the sympathetic nervous system do? It dilates. And therefore the pupillary dilator muscle is overactive. So it's this loss of balance because we no longer have the Edinger-Westphal nucleus because of the pressure on the nucleus from the brain. So the brain will just put pressure on here. And this is called cranial nerve 3 palsy or surgical palsy sometimes because of the bleed rather than a pathological consequence like a stroke. Okay, so you examine the patient, you discover poor muscle tone. Oh, okay, what does that mean? So what's the definition for muscle tone? So there's many different ways to define this. A simple way to say it is the passive partial contraction of muscle at its resting state. And this sort of makes sense because if you feel your muscles, there's a certain background or baseline level of contraction that you have, and it's passive. Now, if you're more muscular, you train more, you might have a slightly different muscle tone. However, if you have too much muscle tone, so hypertonic, then you'll have the muscles will be unusable. And if they're hypotonic, then they will also not be at their optimal use. So this is why a good muscle tone, you need to have an optimal muscle tone for both health and performance. So how would you test muscle tone? So we touched upon this briefly. So you can test it in two ways. You can test it in a passive movement. So you ask the patient to remain completely relaxed, and then you try to passively test the range of motion. Or you can do tendon reflexes. And tendon reflexes, if brisk, will indicate increased tone. I'm going to set up the next slide because give me a second. Briefly. Need to set up the other slide because I changed the order here. Apologies for that. So the next question will be a labeling exercise. So our labeling exercise will involve this aspect. So this is the brain, and it's of poor quality as you'll expect in exams. And it's asking us about the different parts of the brain. This might be quite daunting, so let's see what we can recognize. So this here is the central gyrus. And this is what splits the brain with somatosensory and motor. So if it's behind this line, this central gyrus, it's sensory. So that A would be sensory. If it's afterwards, called the precentral gyrus, then that's the motor area. That's the motor area there. Then we move on to C. So C is quite tricky. Oftentimes people confuse this with E, which is Broca's area. But C is the primary auditory cortex, and it's found within the temporal lobe. That's the temporal lobe. If you want a more detailed breakdown of this, then just look at one of my videos. It's under past live stream, which describes the brain and the different sections of the brain. That's the auditory cortex. D, it's the back. So this is the occiput. So it's labeled posterior. So that's always the visual. That's the visual cortex. Then we have E. And E is Broca's area. And Broca's area is very important because that helps us with the language. And then we have Wernicke's area as well. Now, the reason these parts are important is because if it's on the left-hand side, so if you're right-handed, your Broca's area is on the left-hand side. And if you have difficulty with speech and you're right-handed, then it's highly likely that the lesion is on the left side. Whereas if you're left-handed, likely to be on the right-hand side. However, this should not replace imaging, but it's roughly that way. So if you're right-handed, it's going to be 90% of the time on your left-hand side, and vice versa. Now, if you have damage to either the Wernicke's or Broca's, you'll have aphasia, where you either have word you can't speak or you can't understand language. So moving on, which part would be damaged? When damaged, would have hemiplegia on the contralateral side. So the way this works, we've discussed this in the previous scenario, we have decussation. and that occurs at the medulla. So if we damage the brain on the left hand side, then it will affect the right hand side due to the decussation at the medulla. So if we damage hemiplegia is inability to move. So that's half of our body is unable to move. And since that's the motor area, that would be B. So if there's a damage in B, which is the primary motor cortex, then we will get hemiplegia on the opposite side. That's B. And why is this effect on the contralateral side? Well, we discussed this before. It's because 85% of the pyramidal fibers decussate at the medulla to the contralateral side, the opposite side, and they supply the other side there. Therefore, that's why damage to the left side of the brain will cause right hand and right lower limb weakness. Okay, so we do an X-ray, we do some imaging. X-ray shows a fracture of the left parietal bone, specifically the anterior segment. So you think, okay, CT scan. In real life, not in exam world, but in real life, you would do a CT scan immediately because of the suspicion for the brain bleed. Now on the CT scan, you have a dense area on the left parietal bone, and you've identified this as a hematoma. Dense areas on CT always look as a hematoma. There's always blood. And the question's asking you which artery is damaged. So this is a stereotypical scenario where you get damage on the parietal bone, on the temporal bone, on the a blow to the temples. This could be either someone's assaulted you, had a road traffic accident. And there is an artery which runs through there called the middle meningeal artery. And it runs through an area of the skull called the pterion. This is answer the next question, the pterion. Now, what is the pterion? So the pterion is this unfortunate area right here. It's the weakest part of the skull because that's where the parietal bone, the frontal bone, the sphenoid, and temporal bone all join together. And to add insult to injury, it's also where you have this artery running through. Now, if you get hit here like a baseball bat or a trauma, the bones themselves can lacerate this artery. And since it's an artery, the bleeding will be very quick. And this can cause rapid deterioration. Which leads us to the next question. What type of hemorrhage is this and why is it dangerous? So, as we've said before, this would be an extradural hemorrhage. And the source would be arterial blood. Now, the reason this is dangerous is that our skull is fixed at the sutures, meaning we have a set intracranial volume. If we have an arterial hemorrhage, this rapidly increases the volume within the brain, leading to increased intracranial pressure. This presses on the brain and then predisposes it to herniation, as we've seen, because the brain goes through and pushes on the medulla and the midbrain, or it can cause ischemia because there's not enough blood going to the brain. And when you have this extradural hemorrhage and you've detected it and you have rapid deterioration, you need to carry out a craniotomy. What is a craniotomy? Craniotomy is a very barbaric way to treat this condition, but it's very effective. And it's to drill a hole into the skull. And by drilling this hole into the skull, we relieve the pressure and we can drain the blood. Now, here's a picture on CT. So this is the density here, right? This is the infarct. This is the area of blood. As you can see, it's very different from the surrounding brain. The normal brain tissue has all these little squiggly lines. But here, there's none of that. That shows blood. Now, if you relieve the pressure by a small hole, it doesn't even have to be a big hole, suddenly there's no downward force. If you can imagine, this blood was pushing the brain downwards, trying to push it downwards, like this. But if you remove that blood by releasing it through the craniotomy, all of a sudden, the brain goes back and there's no downward pressure. So in this patient scenario, there was downward pressure. It pressed on the midbrain, which pressed on the nucleus that's responsible for the constriction of the eye, therefore getting you dilatation. And just a brief overview of the layers of the meninges. So we have three main layers. We have the dura mater, which is the tough outermost layer. It's fibrous, it's fused into the inside of the skull and has infoldings. You also have the next layer, which is the arachnoid mater, which is granulations that drain the CSF. This is what it looks like. It's a thinner layer, and these granulations pass through the dura into the venous sinuses, and they help drain the CSF. Then we have the pia mater. So the pia mater is right here, this area, and it's closely adhered and surrounding the brain. This pia mater is important because there's a subarachnoid space where you get blood vessels which supply the brain, and these are important for its blood supply. You also get hemorrhages in all these spaces, so you can get hemorrhages in the subarachnoid space. You can get hemorrhages within the dura, so it's a subdural hemorrhage, or you can get hemorrhages outside the dura, which is what we had in this scenario. So there's some more bonus questions for this scenario. So the first one is to describe the arrangement of the meninges in the cranial cavity. We already did that. So we have the scalp first, then the periosteum, then the bone. Then we have the dura mater. We have a periosteal layer, which is adherent to the skull, and a meningeal layer, which is adherent to the meninges. Arachnoid layer, pia mater, and then arachnoid vessels. All these blood vessels can be sites of blood within the subarachnoid space, which would be a subarachnoid hemorrhage. In the subdural space, which is a potential space, it can be veins, so the bridging veins, rupturing and causing bleed, and arteries in the extradural layer, which is between the dura mater and the skull. What is the difference between spinal and cranial meninges? This is the question we got asked in my exam. The cranial ones have an epidural space, which is a potential space between the skull and the periosteum, whereas in the spine, it's a real space. This is where the epidural comes through, or spinal anesthetic. You put into this space between the dura and the vertebrae. We have the dura mater, which is double layered. So one is attached to the inner skull, and one is attached to the meninges, whereas in the spine, there's only one. You also have the subdural space, which is a potential space in both cases. You have arachnoid mater, which is attached to both inner side, subarachnoid space, which is a real space, and the pia mater, which is attached to the CNS. And in the case of the spine, it's expanded as denticulate ligaments. Now let's talk about the differences between different intracranial hematomas. I think this is a good picture to keep in mind. So the epidural or the extradural hematoma is the same thing. It's found in the epidural space. Vulnerable vessels is the anterior branch of the middle meningeal artery, and this is an arterial bleed. It expands rapidly, rapid deterioration, and changes in neurological function. The second one is the subdural hematoma, and that's between the dura and the arachnoid mater. Vulnerable vessels is bridging vessels, usually veins, and the bridging veins become stretched or sheared. Most common scenario is an elderly person who drinks, they've fell, and this slowly expands. And it's because it's a venous bleed. Then we have intracerebral hematomas. This is deep within the substance of the brain. This is usually severe motion during contusion or head injury, causing a bleed. Commonly happens in the frontal or temporal lobes. And the temporal hematomas are much more severe because it can affect speech and function and can cause herniation and a midline shift. So this here is known as a midline shift. It shifts to the side. Question 4. Explain what effect increasing the volume of the hematoma has on intracranial pressure. So we talked about this briefly in the previous question. The graph to draw, so this was a question that appeared on my thing. The graph to draw is the raise in intracranial pressure. So you have the ability to compensate is quite good for the brain, given that it's a fixed volume. And the reason for this is something called the Monro-Kelly principle. And the Monro-Kelly principle states that the intracranial pressure will be maintained as the volume expands. This is known as compliance. And it is the ability of the brain to maintain this raised intracranial pressure through compensation. And it does this by draining CSF and draining the venous volume. These are the only two substances that can be changed. So it can change the amount of venous volume that's being drained and the amount of CSF being drained. However, once we reach a point where there's too much of a mass, usually 100 milliliters in the brain, the intracranial pressure will start to increase exponentially. And that's because you've exhausted all the CSF and venous volume that you can. Therefore, you get no drainage. And then the second question here, state the possible consequences of an increasing mass of hematoma. So, increasing mass of a hematoma will mean that the pressure gets higher. But why is the pressure getting higher important? Well, the cerebral perfusion pressure, the CPP, is calculated as the mean arterial pressure minus intracranial pressure. Now, the mean arterial pressure is what you get in your blood. So that's your heart pumping. As the mean arterial pressure starts to approach ICP, or I should say, as the intracranial pressure rises and becomes equivalent to the mean arterial pressure, the pressure gradient becomes altered. And this means that the cerebral perfusion decreases. So if you have too much intracranial pressure or if you have too low of an arterial pressure, then you won't be able to supply the brain. And this is terrible because the brain needs a lot of blood. This causes hypoxia, ischemia, and it can eventually lead to secondary brain injury. Now, this is an example of a head and neck question incorporating multiple concepts, having to draw something, knowing the volume versus ICP, and understanding the consequence of a hematoma. And this sort of question can come up quite commonly. Sometimes drawings might be useful, and the head and neck and neuro topics some questions might use multiple topics and multiple facets to answer questions. So do watch out for that. I hope that has been useful. Let me know if there's any questions, if there's anything else you want me to go over. And if not, well, hopefully that was enjoyable. Hopefully that was useful and that it helped contribute to your revision. And if there's any questions in the chat, just feel free to ask. And if you have no questions right now, I do have an email address. I'll just put this down here into the chat. And if there's any questions, just email there, and I'll try my best to answer. I've quite a lot of free time right now because I graduated, and I just have P for P, so I'm willing to help you guys as much as possible. Great. If there's no more questions, then I'll just end the stream. Thank you everyone for coming and tuning in. If you want to replay this, then that will be available later on. YouTube just takes a while to upload everything. And once it's uploaded, then you can just watch it at any time. I will also have it time-stamped, like with all my videos, so you can just click to the video that you want without having to scroll through the whole thing. So I hope this has been helpful.